And if you want to call the meeting to order, I will catch up.
All right, I call the meeting to order at 10:34.
Thank you.
Could you please do the roll call, Shelley?
Amber Rice. Brian Smith.
Present.
Chester Key.
Present.
Jason Johnson. Chris Rummel. Chris Long.
Present.
Matt Shaw.
I'm present.
Orlando Alporto.
Present.
Ryan Harold.
Present.
Sandy Nygaard. Sharon Hollingsworth. I see you on the video.
Present.
Phoebe Merrill.
Present.
And Troy Hoke.
Present.
I'm counting 10. We have quorum.
All right, thank you. Good morning and welcome, everyone. And thank you for attendance today. The first item in the chair report is the attendance report. That should be attached to the materials you received. Please keep in mind that if you miss 2 consecutive meetings or more, someone from the Bureau will be contacting you to determine if you continue to have any interest in serving on the committee. I'd like to welcome Troy Hoke. He's a battalion chief and paramedic at the City of Cottonwood Fire Department. He's also the pre-hospital care program assistant at Verde Valley Medical Center, and he will be representing the northern region. We currently do not have any vacancies on the committee. An update on the work group that was formed to create the training curriculum for STRs for EMTs. They did meet on September 21st. Part of that will be coming forward to us later today on CPAP for STR for EMTs. The other section was supraglottic airways. They did not get that finished up at that meeting. They'll be scheduling another meeting to continue that later on, so should be coming back to us at our March meeting. There's a link for the 2023 meeting schedule if you need to get your calendars in order. And next will be the Bureau report. Chief Garcia, is she on the line?
Vice Chair Smith, appreciate you running the meeting, Brian. Some quick updates. This week is National Crash Responder Week. Governor Ducey has declared November 14th through the 18th Crash Responder Safety Week in Arizona. And we are acknowledging that from 2019 to 2021, there were more than 100,000 traffic-related crashes involving injury or death in Arizona. And we want to remind everyone to move over and slow down when you see flashing lights. We shared a blog this week, and we want to continue to promote traffic incident management courses here in the state. We have a link to the AZ Traffic Incident Management website. We can share that in the chat for folks that are interested in those courses. And for additional questions, please reach out to David Harden. Adam, can I ask you to help me drop some of those links in the chat as we go through updates? On the funding side, the department has identified a small amount of funding to support rural paramedic education. We want to thank our regional council partners for helping us to identify how to distribute those funds within each region. In the state of Arizona, we've seen our state invest a significant amount of resources into nursing education, and we are hopeful that we can identify additional funding and resources for EMS education as well to be able to maintain our workforce here in the state. On the IT side, we have a number of projects that are ongoing. You all have heard us talk about our EMS portal and updates being planned for the new year. We will be coming back to committee meetings like this one in the new year to demo the new EMS portal, and we look forward to sharing a lot of the new features with you all in the new year before that new system goes live. There is another link that we will drop in the chat to highlight the new 911 dashboard that has gone live. The department is planning a blog update on this new 911 dashboard and the EMS and trauma data visualization website. More to come on that. And please let us know if you have any questions as you get to take a peek at that new 911 dashboard. The other IT update that we've been sharing today is our AZ Peers database is going to the new BEMSTS version 3.5. I know this isn't a surprise to any of the providers in the room that report EPCR to our state system. Big thank you goes out to Ann Vosbrink and Avondale for being the first provider that has switched over to version 3.5. Our state is one of the first states that is now accepting BEMSTS version 3.5 reports, and all of our agencies will have until July 1st to transition over to that new version. If you have any questions, please reach out to Ann Vosbrink. To round it out, I want to talk about some rule updates that we've sent out via Gov Delivery. Since this committee has last convened, there's been an update to EMS scope of practice based on national standards. That update became effective on September 22nd, and the updated table 5.1 is available on the Bureau website. We've also had an air ambulance rules update that became effective on November 8th. That rule update was intended to allow flexibility in air ambulance mission staffing, including nurse, and nurse paramedic responses. And finally, I swear I'm wrapping it up. We just want to share with all of our providers on the line today that we are seeing, as you all know in the field, a significant increase in the number of RSV and flu cases this time of year that are particularly impacting our pediatric population. We want to continue to work closely with our healthcare coalition and all of the stakeholders to really make sure that we're monitoring bed availability and pediatric surge capabilities right now. And if you have any questions, please don't hesitate to reach out. I have Adam Rodriguez sitting next to me, who is our EMS for Children coordinator. And we want to make sure that we stay in touch with you all if you do have any questions or resource needs related to pediatric surge right now. I am going to transition to introducing some of our new Bureau staff in the room with us today. I know we continue to introduce you at all of these meetings. We have Russ Lindholm, our new EMS regional coordinator for the Western region. Stephen Ferris, our new EMS regional coordinator, primarily working in the Central region. And then we also have Brian Hubble, new CON and rates manager here at the Bureau. And I think joining us remotely a little bit later, Jeff Kerr, compliance and enforcement manager. And we just want to thank everybody that has joined the Bureau most recently. They bring with them great backgrounds and are great resources to the community. So thank you guys for joining us. Next up, I'll turn it over to Dr. Bradley.
Thank you. So I know we mentioned this at pretty much every meeting, but just want to reiterate that the Bureau was awarded the FR Care grant for an additional 4 years. That started the grant cycle on October 1st. The focus for this next 4-year cycle for FR Care is twofold. We're going to continue the law enforcement, naloxone distribution and education, but also really starting to focus more of our efforts on naloxone leave behind programs for EMS agencies. The website does have a number of links if anyone would like to kind of start that now, but the goal as part of this program will be to really develop educational curriculum, things that you can utilize, go live with, and we will have resources to order naloxone as well. Julia Vinton is the lead for that program. As we get the grant process kind of started in the next couple months, we will send out quite a bit of information to EMS statewide to help facilitate this program and grant. All I have. Thank you.
Thank you, Dr. Bradley. And TJ McKay, have you been able to join us remotely today? Do you have updates on training programs, National Registry, and SMSO?
I do. Good morning. So most of the updates are going to come from the recent National Registry Board meeting that took place on November 9th of this year. One of the things they wanted to highlight, and I think it's something most states are experiencing, is they're continuing to increase the number of certified providers and have been so since 2015. The problem at the workforce isn't the numbers, it's where they are working. So a lot of the folks are obtaining certification and retaining certification, but a lot of the providers are moving to other positions rather than EMS. They've got 3 strategic objectives that they're working on that will be finalized at their June board meeting of next year. One is an item management system that helps with their internal writing and publishing of items, so they don't have to rely on partner agencies to complete those tasks. They're implementing a new customer relationship management software package. It's supposed to replace the old system, and according to their initial reports, is much better in meeting their goals. They're also working on increased marketing and branding of their services, and they're going to create a new mission and vision statement, which is going to lay the foundation for all their future work. The EMS basic life support practice analysis is underway. They're sending out 18,000 invitations to participate in a survey to determine the knowledge, skills, and abilities needed to be successful in the performance of day-to-day work for EMR and EMTs. And that's going to help to support the BLS redesign projects that's coming over the next few years. The ALS redesign project, they updated that July 1st of 2024. The new ALS exam will launch. Psychomotor is not going to be available to candidates in all cases, but there will be some exceptions that are considered to that. They expect completely ending the psychomotor exam in June of 2025. The National Continued Competency Program, the NCCP, is currently being updated. They are not looking necessarily to change the total number of hours, but to adjust the hours based on content that is being determined by practice analysis currently. Again, they're going to make a data-based decision on the number of hours in every given subject. So that'll be coming soon. The National EMS ID is gaining more importance in a variety of areas, especially with some of the documentation items that they have coming forward. They had some concerns over cards and the creation of invalid credentials on individuals. So they're looking to track that more. And one of the other items they're looking to use the National EMS ID is to track attrition. So they're going to be pushing for programs to start that process earlier so that they actually have the number of students who start programs versus the number of students who actually successfully finish a program. There are a number of liaison updates from different organizations. NHTSA's got a number of meetings, some white papers coming out. There's going to be one over the COVID experience coming out by Christmas. They have a few projects that they're going to be working on. One associated with NSEMSO is going to be providing some safety standards and some testing of car seats used for ambulances. That'll be coming in the near future. The AHA has got a new website platform. It's got a number of CE items available. It's got different methods of accessing and providing services to end users. They're actually developing an advanced life support course for stroke, similar to ACLS. That should be coming soon. NAEMT's got a number of new training centers. They are in total about 2,500 right now. They're working on a resiliency course in mental health, an EMS safety course, a new PHTLS book, and a community paramedic program / course that's coming in the near future. And that's about it for my report, unless anyone has any questions for me.
Hi, TJ. It's Brian. I do have a question.
Okay.
Do you have any updates on the Patient Access to Emergency Medication Act that was passed in November of 2017? And on December 4th, it's going to be 2 years since the first set of rules comment closed. And so I've been trying to keep up on other organizations and whether anything is coming out on that. But are you aware of anything on a new set of proposed rules? There was a bunch of significant comment made on it, and I'm supposing it's not going to go through in the way it's currently formatted.
I have not seen anything new on that, but I can look into it and I'll get back to you specifically.
Okay. Thank you all for your reports.
Brian, there's a hand up, sorry. Where does question, Rob Gibbons?
everybody, just really quick. Sorry, wanted to jump in. I wanted to add on to something TJ said. So I was, if you guys need help with anything NAEMT related, I'm the state education coordinator for NAEMT now. So if you need anything PHTLS, AMLS, anything at all, wanted to throw it in there, please reach out to me. I'm getting into my new spot here at Chandler Fire Department, and if there's anything I can do to help you guys, TJ knows how to get a hold of me. I threw my email in the chat. So if there's anything you need whatsoever, please let me know. So thank you.
All right, thank you all for the reports. Moving on to discussion and action items. The first item is to amend approve the draft minutes from the July 21, 2022 minutes. So could I get a motion to do so?
This is
I
Sandy.
got Jason in the room. Just making a motion.
In a second.
Sandy.
Thank you, Sandy.
All right, does anyone have anything that they need to look at updating or revising in the draft rules as they've been sent out?
Got rules on the brain.
Or excuse me, draft minutes.
Nobody in the room is advising to edit.
All right. Can I get ayes from everyone who approves the minutes as drafted?
Aye.
Aye.
Any opposed? Any abstentions? Motion carries. The next item is to discuss, amend, approve the draft training for the national guideline for EMS field triage of injured patients. Can I get a motion to do so?
Got Jason in the room.
So moved. Matt.
Matt, second.
All right, so this training was developed in response to the changes that the ACS has made in the field triage guidelines. I was a part of that committee, so I can give a brief explanation as to the reason for this. This is quite a bit of a departure from the way these guidelines have been written in the past, and so it was felt like there was a need for some education on this. So we formed a work group, it met, and this is the proposed training. So does anybody have anything up front that they think needs to be changed in there?
And Brian, this is Gail. Just to advise as well, Dr. Munn is working on recording this, and it's almost complete unless this committee votes any changes, that this will be built into Articulate format, which is an online training platform that you can upload directly into your training software, and that should be available within hopefully the next few weeks. So if this committee has any changes, they'll make sure to incorporate that. It'll be a similar format to the decision-making capacity refusal training that was put out, I think earlier this year or last year. So we do anticipate this will be done well before the end of the calendar year.
I will add also that the work group has added some kind of update refresher on traumatic brain injury and the EPIC product or the EPIC project at the end of the presentation. And there are also some examples of how to triage and questions that you can participate also towards the end of the presentation.
Oh, sorry.
if approved, this will be available both in the PowerPoint format with the presenter notes included, or in the recorded format as well. So we will make sure that both are available publicly.
All right, are there any other questions or recommendations on this draft? All right, hearing none. All those in favor of moving forward this draft, please say aye.
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 Any opposed? Any abstentions? The motion carries. Thank you.
Sweet, thank you.
All right, the next item is to discuss, amend, approve the draft training on pre-hospital death notification. Can I get a motion?
I got Jason in the room.
So moved, Matt.
All right, I was not part of this work group. Is there anybody online that can give a brief report on this training?
Matt Shaw, I believe, were you part of this one?
Yeah, sorry. I was just trying to get my thing unmuted. Yes, so essentially there was sort of recognized that there was potentially a gap in training from paramedic school to being able to actually provide death notifications to family members after cardiac arrests and in cases like that. And so we sort of set out to come up with a training that largely had already been created from other places that we could apply for our EMS providers. The grieving mnemonic was already a pre-established mnemonic with training that went along with it. We thought that it was pretty simple and easy to implement, and so we modified just some of the training to be specific to EMS as far as resource availability and things like that. And that's sort of this is the training that we've come up with.
All right, thank you. I do have some items in here they're mostly typographical things. Does anybody else have anything?
Go ahead, Brian.
Okay. On page 23, and these aren't numbered in here, so here's page 23. On the second bullet, it says consider covering some or most of the body with a blanket so that families, I think that should be the family.
All right, I got it.
And then on page 27, on patient's present condition, the third sentence, it says the patient is noted to have bleeding noted to the back of his head, and that second noted, I think, is redundant. Just needs to say the patient is noted to have bleeding to the back of his head.
All right.
Page 29 and paragraph C, it says you have a hard time understanding and accepting, and that should be Jose's death. The E is missing.
Good catch, Brian.
And then on page 30, on background, first sentence, Mark is a 22-year-old who is home from college. He went out last night with his friends, and it is unclear what time he returned, and that should be returned.
All right, I'll make that edit.
And then page 32, this is in A. It says you are shaken/upset, but you are expecting your son to be already now that EMS is here. And I'm not really sure what that's supposed to say. It really doesn't make any sense to me.
I'll change it to all right.
Yes, that sounds like a good plan. That's all I had.
Thank you, Brian.
So glad you're here, Brian.
Thank you, Shelley, on the fly.
Eagle eye, Brian.
Are there any other comments on this draft?
Brian, this is Gail. I just wanted to thank the work group that put this together. I know this has been on our list of topics to cover for at least probably 3 years pre-COVID. We've had this on the list of educational items to put together. I know, Matt, you were the one that initially suggested this. So I think this is important. We are seeing, as was demonstrated in the share presentation earlier, we have a higher percent of cardiac arrest patients that are not transported, which means that EMS is doing this on a more frequent basis. And so we really want to provide some educational opportunities for them. So thank you very much for working on this.
All right, hearing no more comments. All those in favor say aye.
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 Any opposed? Any abstentions? The motion carries to move that with the changes as noted. The next item is the draft STR for EMT airway/CPAP. And I'd like to get a motion to discuss, amend, and approve.
Got Jason raising his hand in the room. Is there a second?
Matt will second.
Thank you, Matt.
And Brian, if I could maybe give a quick kind of update as to why we are putting these together.
Yes,
Everyone
please.
that's not familiar. So one of the things that the Bureau had looked at was there is a several hundred-page document of kind of an outline version for education and training on all the SDRs that used to be in scope of practice. With our most two recent updates to scope of practice, we really eliminated a large majority of the SDRs. And what we realized is the education committee had already put together some training PowerPoints, which were much more usable than an outline format. And so the education committee had voted to kind of go through the rest of the SDRs that are now still in place and try to create these training PowerPoints that agencies who do want to implement these can implement this. We recognize that many of the agencies that are using EMTs to do SDRs are more rural. They may not have the resources available to put together their own educational training. So just a little bit of background as to why this was being put together. Thank you.
All right, is there anything else? I've got a few, mainly technical / typo errors.
All right.
Okay, the first one is on page 13.
Go ahead.
It's the fourth bullet. CPAP is a successfully used as an adjunct, and I think the A should go away. So CPAP is successfully used as an adjunct.
All right.
On page 14,
Okay.
there is, both on the first and third bullet point, there is a reference to, in capitals, NIV.
You need a
I think
parenthetical.
that should be both of those should be appropriate for non-invasive positive pressure.
Okay, I'll explain the acronym.
The NIPPB.
NIDPP, I think it would be, rather than. Okay. The next one is on page 17. Oh, I just had a question about some of the contraindications. I looked at some other training programs and found recent facial or gastric surgery, and maybe those are relative and maybe they're not important. The next one is facial trauma / deformity / burns that inhibit a proper mask fit.
I think the facial trauma and burns that may inhibit proper mask fit would be a useful one to add. I'm not sure about the recent kind of facial surgery, just because if someone needs this and this is their only skill in the pre-hospital setting that they have available, this may be a life-saving intervention, but I do think that the facial trauma and burns affecting masks. Do you want to type in the chat, or do you want to say again the exact verbiage so Shelley can get that?
Do we want to put that in relative or in the main contraindications?
I would say if it's facial trauma or burn that's affecting mask fit, then that would be an absolute contraindication if you can't get appropriate mask fit.
Right. Okay. So facial trauma / deformity / burns that inhibit proper mask fit.
All right.
Okay, and then the next one is on page 21. On the second bullet point, there's in PPV, so non-invasive positive pressure ventilation and IPPV, like on that other one.
All right.
Okay, then on the next page on 22, first bullet point, CAP should be CPAP, CPAP.
All right.
And then after that comma, there is an observed worth use of CPAP. And I'm not sure about that worth terminology, but it needs to have the E dropped off regardless. So it'd be observed worth use, and then the PF should be OF. I'm just not sure if that terminology is really what we're after or not.
Can we change it to worthy with a Y? Worthy with a Y?
I think maybe there's an observed benefit of CPAP.
Yeah.
Might be a better way of.
Yeah, I
Okay.
think benefits correct.
That's better.
Yeah, it's something about it's worth the use of CPAP.
I think
All right.
benefit is better. And then on page 28,
Go ahead.
I have a question about CPAP needs to remain continuous and should not be removed unless the patient is, and I questioned about whether hypotension should be added in there, not responsive to fluids, although this is an EMT and maybe they won't have all IVs, but it seems like when they become hypotensive, particularly for those who don't have as an STR IV access, that do we want to wait until they're in cardiac arrest before we remove CPAP? There is,
I guess, Brian, my only concern with doing that would be if you had an EMT who's utilizing this, and this is someone in respiratory distress, and they're, how do we define hypotensive? So if their systolic 95, do we take off the ventilatory support? and potentially worsen their airway management for relative hypotension, kind of what would be your cutoff? So I think from this perspective, this may be better left up to the medical director, or we could add, contact online medical direction if concerned regarding hypotension. But I don't think I would take that off, utilize that as a reason alone to remove CPAP.
Okay, just the reason I brought it up is because so that's page 28, 29, and 30. On page 30, the last bullet point, it says hypotension can be treated with administration of intravenous fluids or decreasing or discontinuing CPAP. So if that seems like it's reasonable for that to all stay there, then that's fine. And that was all I had. Are there any other comments?
Just to clarify, page 28, I'm adding, no, I'm not, okay.
You are not had, no.
All right, thank you, Brian.
All right. Hearing nothing else. Everybody who is in favor, please say aye.
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 All those opposed, please say no. Any abstentions? The motion carries with the changes noted. All right, the next item is a standing item. It's to review the table of training modules and approve forming a work group to update or create materials as needed. Is there anything on this list that's not being currently worked on or that anyone feels needs to be amended or revised at this point in time to form a work group? Okay, I saw 2 items on here that were scheduled to go this year, and I went back on a few of our minutes to see if we had addressed anything that they were okay and didn't need anything, and I couldn't find anything. So the first one is the use of naloxone by law enforcement for opioid overdose training, which would also require participation of AZ Post, I believe. And then what should go in your EPCR?
So the law enforcement naloxone one was updated at the end of the FR Care grant period, and that is an online module. So I think that's the one that was built into the Articulate system that any law enforcement officer can actually just log in directly and complete it, and they would get a certificate of completion for that. So we can, I think, update that one because that one was done.
The dates are wrong on this.
So we could go to 2025 since we've moved from 2 years to 3-year reviews?
Yeah, and that one was definitely updated. Was it updated 2022, I believe, Shelley?
I didn't change the date, so maybe offline I can clarify.
That one has been updated though, so I think we will follow up on that one. Thank you, Brian.
Okay, and then I guess what should go in your PCR was the other one that was on the list for this year. And if anybody feels there's a need to revise that we could form a work group now. Otherwise, I think we could move it forward to our next meeting and have it on an agenda item to be sure that we documented it had been reviewed and move it up another 3 years at that time.
That one is pretty old, Brian. It might be, I'm not sure that we did many updates the last time around, and especially as we are kind of coming up on an update with NEMSIS 3.5. I wonder if this one may be one that we want to make sure there's nothing that's contradictory with the new NEMSIS 3.5 update coming up.
Okay, can I get a motion to look at what should go into your, what should go in your EPCR?
To form a work group.
To form a work group.
So motion.
Second. Do you need any seconds?
Sure, I second Matt.
And I'll make sure Ann participates.
Okay. Any other comments on this? All right, all in favor, say aye.
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 Any opposed? Any abstentions? All right, the motion carries. Is there anyone who is interested in participating in this at this time?
Jason raised his hand. Anyone else in the room? Anyone on the call virtually?
This is Sandy. I don't mind helping.
All right, thank you, Sandy.
This is Rob. I'll help out wherever I can too, you guys.
Ron Gibbons, thank you.
And there's a chat that says Troy would be interested.
Thank you, Troy.
All right, if anyone else is interested, please contact Shelley and let her know in the meantime, and we'll be looking for scheduling on having a meeting for that work group later on. Thank you.
Hey, Brian, I'm sorry. I was having trouble with my speakers at the beginning. Are we going to have a repeat meeting for the supraglottic training since that didn't come up today?
That is my understanding is that there's going to be another meeting to finish up the supraglottic training.
Okay, sounds good. Thank you.
This is Shelley. I'll communicate with Amber Rice on that follow-up date for that work group.
Thank you, Shelley.
One other topic that I do want to put out to the group to consider, as we saw the data presented this morning at TEPI, when we look at ground level falls and hip fractures, this is a pretty sizable population in Arizona. And is there the potential to put together some type of training for EMS? I know many community paramedic programs do fall prevention mitigation training for EMS providers, but there is some of that training that is really relevant for a 911 call. I think crews go on a large number of fall injury patients, minor fall injury calls. Are there some minor things that we could create in a training curriculum to help address and potentially prevent a future fall? So I'll just put that out there as a future topic to consider as well.
Yeah.
Right, so we can add that to the next agenda then.
All right, I'll make a note, fall prevention mitigation training for items to be considered for the next meeting.
Yeah, thank you. Next item is to discuss schedule of training review and coordination with PACES. So there's a number of educational materials that PACES has developed. I'm assuming that that part of this also is that there may be other areas of pediatric concern with some of our other training that they would like to have more coordination or have some coordination with us on these items and in terms of the upcoming reviews.
So Brian, this is Gail. One of the things that we have noticed is as PACES has fallen under the Bureau of EMS and Trauma in the last few years, we really want to try to make sure that there's good collaboration between the two groups. And the Education Committee has done a fantastic job in the last few years of creating these training curriculums. And sometimes we don't realize until we've approved them that we probably should have had more of a pediatric focus on this as well. So what we'd really like to do is to try to find some way to get a PACES representative on any future work groups that we have moving forward. So Adam, I don't know if you wanted to tie in with that.
No, we just we wanted to use that to accomplish a couple of things to keep both Education Committee and PACES abreast of what we're doing in terms of developing pediatric materials, and two, to sort of circumvent the time gap because PACES occurs just after the education, and so we don't necessarily. Or perhaps we can circumvent that gap in time by bringing education members on board, not in an official format, but in a voluntary format. And a big thanks to Chris Ramos, who's already helped to bridge that gap for us. And so what that'll allow us to do is bring forth materials directly into the meetings that, into meetings that are occurring the same day as PACES, so they can be looked at in sort of a much more quick format instead of waiting the months in between meetings to bring it up, to have it on the agenda for education. So the ask is just a couple of volunteers. Again, Chris, thank you, to come over to our work groups and just make the Education Council aware of the training, and also to bring it forth to them for a placement on their agenda, and as well to not reinvent the wheel. Perhaps the Education Committee already is aware of resources that we are creating trainings to use, and so we think it'll be synergistic in that regard.
Thank you.
All right. Any other discussion on that? All right, we'll move on. Discuss seeking stakeholder input on critical care certification and community paramedicine certification. There is a survey link on here that has 3 questions on it that I looked at yesterday. They are not necessarily easy. You may want to do some work. There's the 2 of them are hours, topics that you might want covered, and so they're not just simple yes, no answers if you're going to participate in the survey. So does anybody else have any information on this topic?
Yeah, Brian, it's Rach. As we've looked at our rules, both for ground ambulance and then most recently doing the 5-year review on certification and training rules, it has come up multiple times through stakeholder meetings that it would be helpful in our rules to define critical care and community paramedicine. And certainly as we have the opportunity to look at these rules that have not been updated in a number of years, we are soliciting stakeholder input. Just like you said, these are not easy questions, but if the community has any input on standards for critical care paramedic training or certification, as well as community paramedicine training and certification, we would love to hear your feedback. These are open-ended questions, and I hope that helps give some background on what the Bureau and the Department of Health are looking for at this time.
And I think to add to that, these are purposely left wide open so that you can really add whatever you would like to add. If there's a certification that already exists you would like to type in there, or if there's a certain view that you have with experience with your own agency or training program, these are really left open-ended for that reason. So it take as much or as little time as you'd like, but if you have an interest in this topic, which we've heard from many stakeholders there has been interest, please take the time to fill this out. We will be distributing this, I think, in a few different formats to groups to get make sure we get good stakeholder feedback.
Right. And this is TJ, if I could just chime in on that as well. I was with the NSEMSO Personnel Licensure Council this morning soliciting information from around the country. And what would really be helpful is information from our training programs who are already providing credit courses or informal education programs in these topics, just to get a perspective of the in-state to complement the items that we're receiving from around the United States.
I do have one question on this, since it mentions the word certification, and I've made other comments about this topic. It seems to me that if these are certificated positions, that it's going to require statutory changes, because neither one of those is defined in the statute. Has the department decided that they can proceed with a certification for these 2 items without a statutory change?
Brian, it's Rach. Thank you for that question. In our early research on this topic, what we've learned is many states have gone to, rather than a certification, an endorsement in these areas, since there are already existing programs out there. It really is an endorsement rather than a certification.
Right.
And so at this time, we've been researching what that might look like based on other states' models and practices in these areas. And we would be very open to feedback in that arena, Brian, if you did have comments on certification versus endorsement routes. Our basic understanding is our statutes would allow us to go the endorsement route.
Right. I agree with that. And I think I had mentioned, I don't remember if it was at our last names meeting, that it seemed reasonable where we used to have the rule for the hazmat techs, and we've made that into an STR, but it doesn't prohibit us from having a rule written for each of these positions that defined all the things that we wanted to have, and then those would be added in on the scope of practice model. My question is, before we send this out, would it be appropriate to change that terminology or say certification or endorsement before we send it out?
Does endorsement mean something different than certification for our purpose, other than statute versus not in statute?
And I didn't recognize the voice on the line just now. Was that Matt?
This is Matt.
Hi, Matt. Yeah, I think that it would be good to update the language here, specifically under purpose is where I think Brian is going. And Matt, to answer your question, I apologize if I'm oversimplifying this, but what we've seen in other states' models is that your certification would really be as a paramedic, and then you can earn an endorsement in addition to your certification in other areas.
I see. And so that endorsement would then come with whatever extra scope and skills that that DHS and the committees kind of agree to.
Yeah, based on what would potentially be defined in the rules.
Yeah. Okay.
And just from a training perspective on that, the certification generally is the ability to do something. So I get a certificate to teach, and then I get an endorsement in a specific subject. So secondary math, special education, elementary, things like that. So the cert would still be paramedic, and then I get a specialty endorsement that I'm allowed to do in addition.
Well said, CJ.
All right, any other discussion on this topic? No, okay, moving on down the list. Does anybody have any agenda items that they would like to see on our next meeting? All right, if there's nothing right now, please send a note to Shelley, and her email address is down there if you would like to have anything added before the next meeting. Call to the public. Is there anybody out there in the public that would like to address the committee? Hearing none, the next item is upcoming events. There's a list of upcoming events that's attached to your agenda for your purview. Our next meeting will be March 16th, 2023 at 10:30 hours in the ADHS 150 North 18th Avenue, 4th floor ALS training room in Phoenix, Arizona. That's going to complete all of our agenda items for the day. And so I'm going to call the meeting adjourned at 11:28. Thank you for coming.
Beautiful job, Brian. Thank you.
Awesome, Brian.
And can we just throw that paper date up there so people can see it? And if you haven't signed off yet, we have to save the date up for an upcoming seminar, EMS-based hospital and medical direction. We'll make sure this is distributed to everybody on the line through the committee.